Okay, hello, welcome back from lunch. I hope you enjoyed your lunch, and thank you for coming to this session on leadership and implementation and how we can really prevent never events. So we'll be talking about never events and why safety alerts are not successfully implemented, about alert implementation as a window into organizational safety and leadership culture, and we'll hear some real examples from trusts who have learned from never events. And we have three speakers and panelists. We have Nigel Aitchison, who is the Deputy Chief Inspector Hospitals Care Quality Commission. Then we have Dr. Francis Healy, Deputy Director of Patient Safety Insight, NHS England and NHS Improvement. And we have Dr. Timothy Ho, Medical Director, Frimley Health. So without further ado, I will hand over. But in the meantime, again, use Slido, ask your questions for the end. We'll have a Q&A session. So over to you, Nigel, please.
Thank you. Thank you very much. Good afternoon, ladies and gentlemen. Thank you very much for coming to the session. It's an absolute privilege for me to be sharing a stage with Fran and Tim, who I've known and worked with for many, many years. I moved to the CQC about 8 months ago and want to start this session by talking a little bit about the prevention of never events from what we've learned and are learning as a regulator. So for those of you who don't know what the CQC is all about, we are the regulator for health and adult social care in England, and we try and make sure that health and social care services provide people with safe, effective, compassionate, high-quality care, but we also are trying to encourage services to improve, and we'll touch upon some of our work in that area as we go through. There are a number of documents which you'll see on the slides during this presentation, which are available on our website, and I commend them to you because they do contain some of the things that we've learned and, as I say, continue to learn about safety, about quality improvement, about the state of health and care services. So every year we publish an annual review, which we call the State of Care. And for last year, the breakdown of hospital services was, as you'll see on the screen. So about 2/3 of services we rated good. Sort of high single-figure percentage we rated outstanding for services, but you can see about 20 or 30% of hospitals were rated what we call requires improvement, further work that could be done, and a very small number, unfortunately, are rated inadequate, and some of those trusts will go into special measures regimes that you may have heard of. But in amongst that, we rate against 5 domains. Are services safe? Are they effective? Are they caring? Do they respond to the needs of the people who use services? And are they well led? And what we find is that, unfortunately, in the safety domain, there are still some concerns for us with, as you can see, almost 4 in 10 trusts requiring improvement for safety. We last year published a publication on never events, and in 2017-18 in England, there were 468 never events, and I'll not go through all of the domains, but you know the sorts of categories of things that are classified as never events: wrong site surgery, misplaced NG tubes, retained foreign bodies, medication errors, wrong prostheses, etc. And when we had a look at these never events, we found a number of things. We know, and I as a former consultant gynae oncologist, I know that NHS staff do a remarkable job every day, 7 days a week, 365 days a year to keep patients safe. But despite those best efforts, as we can see from our report, never events still happen. I think the fact that they still happen reflects some of the challenges that colleagues face in giving safety the priority it deserves in and amongst those busy days that they have. And our sense is that in reality there needs to be a cultural shift in the way that safety is understood and put as a priority and then managed in our NHS. So what did we find? We found that ever-increasing demand was one of the factors. Hierarchical structures still exist, as you know. Patient safety alerts, which Fran will talk about a bit later on, variably acted upon. And what we found was that the current patient safety landscape is still quite complex, quite confused, and it can sometimes be hard for some trusts to see that wood for the trees.
healthcare is a high-risk activity, and I think we need to recognise it as such. We need to learn from other industries who face these challenges. In those industries, all staff are trained to ensure that everything's been done to reduce the risks to an acceptable level. We know that team dynamics, we know that situational awareness, we know that training in human factors are seen to be central to how some of those organisations do this well. The ability to raise concerns for staff, some organisations encourage and are very open and encourage staff to raise concerns. In others, we find that that's not encouraged. In some industries, safety protocols are followed absolutely without question, and technology is used where appropriate to reduce error. So how can we reduce never events? This is our publication, as I say, available on the website. Everybody has to play a part. So when Bill Kirkup reported on the maternity service in Morecambe Bay, he said, actually, the people that lay hands on patients have got a key part to play in this, but so do the leaders in those organisations, and that's reflected in the work and the findings at CQC, that everybody has a part to play. That leaders in the organisations, they need to understand what's involved. They need to provide that leadership. They need to provide that support. They need to provide a safe space for staff to be able to do this work well. And sort of summed up, that's a challenge to the culture in the organisations and changing our approach to make sure that a just culture is established, where learning is valued and shared, and that we're able to work out solutions to manage risk. So there's a whole list of things, I'm not going to go through them all now, about what holds organisations back, but that culture and leadership we think is really, really important. Yes, there are some strategic barriers, and yes, there are some system barriers, but really that leadership, setting the culture, setting the expectation, and the ability for staff to be able to work safely is important. I'm not going to dwell on this, but again, we've published a couple of reports, and I think these fit very well with the wider work that colleagues in NHS England and Improvement are doing around trying to embed quality improvement as the way that we do business around here. Again, in order to make those bits of work successful, leadership is really key. That ability to empower staff and engage with them to change that culture. Openness and transparency we've mentioned, effective governance processes. This isn't a soft and woolly nice to do. This is a really important part of what businesses should have as their core. And we feel that engaging with us is something that is of benefit to organisations, and indeed, as I say, to us in terms of sharing some of this. So the takeaway learning from the work that the CQC has done on never events is that everyone has a part to play in patient safety. Leadership and developing a culture where open communication across organisations is absolutely key. This has to be done board to board. No one bit of an organisation can do this alone. Humility is important, that just culture, the sense that people feel, sometimes things go wrong. What we need to be able to do is have systems that can pick that up quickly, that can investigate that in a fair and open way, and in a way that learning can come from it. And we also feel that quality improvement that has to be driven from that front line and supported there is also really, really key. My sense of if you're to take something else away, there needs to be a focus on people. It needs to be a focus primarily on the people that use the services that we provide, but also the staff that provide them. We need to give support, encouragement, development to those staff. We need to do that with kindness and compassion, both to the people that use our services, but also to each other as staff, right the way through organisations. And in the very best organisations, what we see is that they are curious. They want to find out ways that they can be better tomorrow than they are today. And that's part, I think, of how we learn, how we hopefully will reduce the number of never events that we see. So that's all I'd like to say before I hand over to my colleague, Fran. Fran, it's over to you.
Hello, my name's Frances. And you'll notice there's a question mark added to my version of the title today. Firstly to say, those of you who've heard me speak at Congress before might know I have a little bit of a tradition of using science fiction or fantasy. We've had the Star Trek Guide to Safety Measurement, we've had the Discworld Guide to Safety Culture. I really, really would have liked to bring you the Game of Thrones Guide to Safety Leadership, But there's always a programme for 2020, so just a chance to lobby Sean. I've left his Twitter handle there if you want to send him a message. Instead of science fiction and fantasy, I'm afraid you're going to get some stables, some horses, and some farms, as well as some harms. Never events have a very specific definition, distinct definition in England. Any of our international visitors might know them as something different. Yet, if we've got the definition right, a never event occurring should be the equivalent of a horse appearing on a motorway. It tells you there could be something fundamentally wrong with the locks on your stable, and indeed probably the fences on your farm. And that's why, in this context of Nigel laying out this isn't actually happening, we've got to think about these recommendations in the report and how they link with our patient safety strategy. I won't be focusing on all the recommendations in the report, but particularly those where leadership and implementation is key. And what I'll try to do, whilst feeling utterly intimidated by the expertise of our chair today, is to point out that if an organisation has issues with implementing alerts and safety guidance, what's going on there probably isn't all that different to what's going on when a clinical team isn't managing to do quite what they set out to do on the front line. And just before I explain a bit more about the combination between alerts and never events, it's worth reminding ourselves of what alerts ought to be. It would be arrogant and unwise to think one page of A4 could fix some of the most fundamental and serious problems in healthcare. We need much longer, long-term programmes for those. But through the national lens of the NRLS, we're privileged to be able to detect, because of a report from Manchester, to put out advice that within weeks or months can protect a patient in Mansfield, in Maidstone, or in Margate. Other alliterative combinations for your own hometown are available. And I can't talk about the brilliant teams, patients, and professional partners who make that translation from incidents to alerts possible. But do please check out these links and learn a bit more. So to explain the variations in leadership we see in the response to alerts and any subsequent never events, I'm just going to use one particular example, airflow meters. We can pause for a moment to curse the international design standards that make oxygen and medical air look as similar as you can see in one of these pictures, and the hospital design tradition that meant we stuck them right next to each other on the wall. But given that was a situation that was not going to change anytime soon, the alert and subsequent advice we issued suggested basically the best way to get rid of that problem was throw your airflow meters in the skip, buy powered nebulizers instead, and that error trap wasn't there in quite the same way. And after that, unintended connection of oxygen to an airflow meter became a never event. And I'm going to give you some examples of some of the things we've seen in some illustrative responses to never event investigations, and how they relate to this analogy of the stable door and the horse that may have bolted as far as the motorway. This first response, perhaps we could summarize that as we didn't actually think we needed to lock the stable door at all. It's highly unlikely, though, that was a casual or a heartless decision. There are an awful lot of cognitive biases that genuinely make it very hard to believe that what happened elsewhere could happen here. And that's probably happened in this organisation that took an alert like that, but believed they didn't need to act because it wouldn't happen there. If we understand those cognitive biases, we can work to overcome them, just as we do in recruitment or diagnostic error or other fields. This one I'm going to summarise as the stable door is still open, but it has a sign on it. And again, this is a genuine belief that is very, very widespread. The that putting a sign and telling people to be careful will prevent error, that a newsletter telling people about an error other people made somehow inoculates you from making future errors. And that's why it's incredibly important as part of our strategy. You know, we build skills and knowledge for everyone who's trying to build safety systems in their hospitals. And we have safety specialists who can help people understand that's not a very effective response. This one I'm going to summarize as stable door is still open and the stable boy is in the naughty step in the corner. Yeah, just because we make someone do a reflective essay rather than put a disciplinary mark on the record, we're still making the same error of assuming we've got to fix the individual, not the problem. And that's why just culture is incredibly important beyond reducing fear and blame. This is what we saw most typically in the trusts we visited in partnership with CQC. They sorted it out, but only for one department or division. Now, we knew we would see this happening in trusts with bureaucratic cultures. It's the nature of a bureaucracy. You hand out your tasks hierarchically, you cut them up to divisions, they report back. We also saw it in good and outstanding trusts. Same problem, different reasons. It seemed related to giving divisions autonomy, trust, letting them do things their way. Now, sometimes that is just extra workload for frontline staff. You imagine an alert that's saying you've got to check and change the hooks on your collapsible curtain rails that help prevent someone committing suicide. If you franchise that out to every single ward manager, it will probably still get done, but at some cost and some inefficiency, and you've got to check it done many times. If it's something like ensuring your junior doctor's induction program tells them they do not check a nasogastric tube in X-ray till they've done 4 criteria training, that just doesn't happen if you're relying on wards, divisions, because none of those are personally responsible for a trust-wide induction. And in the HSIP report, some of you might have seen, all those levels of problems described, an additional one. And the additional one was about finance. After the 4th airflow meter event, nebulizers were purchased using charitable funds. That is an example, I think, of when we say safety has to be the NHS's first priority, this is something we mean. The time and workload of precious nurses who we do not have enough of doing those hourly checks when actually purchasing nebulizers for an entire hospital is probably about £5,000, and those will last 5 years if nobody takes them home by mistake. But somehow that sort of safety expenditure is not mainstream. It hasn't got a slot to fit into, it doesn't happen, and people try and do things the hard way instead. We saw great examples too. Here's a trust that fixed the entire stable block, took it as a trust-wide problem. And here's one that did what you would hope. The Never event made them think about their overall systems. They didn't just fix the locks on the stable, they sorted the entire farm. But, as Nigel said, at the minute, it's very difficult for people to see the woods for the trees. So a core part of the CQC recommendations and the NHS patient safety strategy is to make some radical changes to the whole system of alerts. These are the alerts that came out through CAS the other year. You can see many different types, many different formats. Our own patient safety alerts are just a small part of those. And what we're doing is not only improving our own alerts, but bringing together all these partners, all these other organizations to try and improve the whole system. What is happening at the minute is something like a rule-based violation in the front line, because most of those alerts are not too tricky. Change a pin in a hoist, pull a faulty batch of drugs, you ask clinical staff to read about the symptoms of Zika. Then, when you get something in like, just make sure there is not one girl or woman left behind on valproate without a pregnancy prevention plan, or what looks like a device alert, but actually means you may have some major issues with how cytology and breast screening was done. Those need to land at a different level and need to be treated as complex, trust-wide work. So this is what you'll see from us in Knapsack, and we will hear much more. We'll be able to update you now. We've got a team in post just the last day to start to bring this together. But you should see fewer, better, clearer alerts from all organisations. Ourselves as a patient safety team will be the first to go through the process of being judged by patients, peers, and CQC as an independent arbiter. I am slightly over my time, going to ask for 1 minute's indulgence in terms of those looking at us from the outside think we're incredibly lucky. This was an international panel I chaired last year, and the lady you can see sitting next to me is Deanna, whose baby Grant, who you can see in the picture above, died because of a misplaced nasogastric tube. He died because it was checked using something called the Whoosh test, which is an absolutely useless, discredited test. We successfully outlawed that in the UK in about 2005. It was a tragedy for Deanna and her family and her baby that test was still being used in the paediatric care unit where her baby was. It's also a tragedy for the two ladies you can see sitting next to her. Beth is a nurse in the USA who has known that test doesn't work for nearly 10 years, but has been limited to personal campaigning. And Christina was the manager of the unit where Grant died, and she never knew. She never knew there was a problem with that test. There's no system in her country of telling people you need to systematically change a safety issue. So this is the take-home messages from us. We will be upping our game to make the alerting system the best it can be for you and your patients. And that will have benefits that go far beyond the prevention of never events. But we know it's just the start, and the important part is your response. Thank you.
Thank you, Francis. We're going to move now to Timothy Ho, who will take us to the final presentation in the session.
Right, thank you. I'm just going to go from the other end, actually, as a provider, and I'm not going to tell you the perfection that we have. In fact, I'm going to give you examples about how we dealt with a whole load of spikes, and I've got actually most of my patient safety team in that front row, so they will correct me if I say something which isn't correct. We've historically been very robust at dealing with never events. We've always had very low numbers, but something very bizarre flagged in 17-18, and through that year, despite what we did, various events kept on flagging. Now, I'm pleased to say that the numbers have come back down to a very low level, but 17-18 certainly gave us some food for thought. And I've listed, so this is, I was going to call this a slide of shame, but actually, this is, I think, it does reflect the honesty that our teams and our organisation do talk about. But clearly, I hope that the numbers wouldn't be this high. So I've listed the different never events that we saw in 17-18. And a lot of them have been mentioned in national alerts. And actually, if you look, a number are very common. So the most common one is problems with left and right or wrong sight. And this is something that we still have to work on as an organisation. And actually, one of the take-home messages I will mention is that dealing with never events is a continuous process. It's like painting the fourth bridge. It's something you have to continuously remind staff. Interestingly, some of the never events are no longer never events. So spinal surgery, I was talking to Nigel about this beforehand. Actually, we realised that actually spinal surgeons themselves can't actually work out a process of how to make it foolproof. And there's been a lot of discussion about how we can actually improve that. Nerve blocks, left and right, is an issue. Wrong moles. You'd think, well, if you take a mole out, it'd be pretty straightforward. There's a mole on my back, please take it off me. what we found out is that if you actually have a patient who's got several moles in their back, you have to work out which mole you want to take off. And therefore, having a process of identifying that, particularly when the patient can't actually point to it, has been an issue. With teeth, and I think taking the wrong tooth out, I think is the most common never event in England. And I could be corrected, but I think that's currently one of the highest never events to be reported. And I'm a chest physician, so until recently we never had a dental unit, but actually I've now got very interested in teeth because of that. And indeed, you would think that even in areas with high levels of staffing and high levels of care, such intensive care, left and right issues wouldn't be an issue. Other issues that we saw, wrong device, wrong implant, wrong lenses, retained swabs, and we've also had issues with the wrong site of administration. So someone putting an oral medication through an IV cannula, which in itself is painful, but you would think that would be quite difficult to mix up. So as part of the learning, and that was the key, is about the learning, we did a thematic review. And we tried to work out what common themes were there. A small number were due to procedures done out of hours or at weekends, so fewer people around. Certainly a common theme about failure to follow policies and guidelines, including the WHO checklist. So we had to have a massive reboot about the WHO checklist. Was it that staff were just going through the process, just nodding through? It becomes so reflex that the actual intent of the WHO checklist wasn't being followed as designed. Areas about poor documentation, so the wrong pacemaker is actually meant to be a defibrillator. So people rushing, thinking, I've done this procedure, it's a busy list, it's a Friday afternoon. And I remember this because it happened the last day of the financial year and when it was notified. So it's something you remember. And one other factor that I think is important, which doesn't always come out, is actually organisational pressure. When there's a lot of throughput, a lot of activity, people are often behind on their lists, the temptation to cut a corner or actually just get yourself back on time is something that you think, well, has that contributed? And certainly that came out in the thematic review that we performed. So what did we try and do about tackling never events? And clearly it was the analysis. Some of the wrong site issues were revisited. People's procedures in theatres about marking and actually teams actually beginning to work together and actually rehearsing. Certainly with the spinal surgeons, I did get them all into a room and actually try and get them to come up with a common policy. But there are 4 ways of doing spinal decompression, and one of the challenges was trying to get everybody to agree to a standard process to actually work through. The importance of team training, I think, becomes very, very clear to me. So although the WHO checklist doesn't generate that, in certain areas, particularly with issues with nerve blocks, just getting teams to rehearse and actually practice, particularly under pressure. Certainly one of the issues that we had with a nerve block was the procedure started late, the patient very anxious, and the anaesthetist trying to get themselves back on track and actually just putting the first bit of a block on the wrong side. The most interesting thing about that case was that the anaesthetist, having realised when the patient's sleep was on the wrong side, actually reported it in real time in theatre. So we knew about it before the patient actually came off the table. And that was, I suppose, A, positive, but clearly I preferred it if they hadn't put the block on the wrong side. Working through operational stress is also a big issue. So when people escalate into areas, particularly during winter, when we've got a lot of pressure on the front door, trying to get patients into the hospital, but still trying to maintain our elective work. Certainly that was a theme that some of our clinicians did mention. And we worked very hard about how do we actually stop that competing stresses about trying to maintain one part of our organisation while still trying to maintain safety. Now, I've put the issue about accountability, and I think Fran and Nigel have talked about no blame, and certainly with blame or pointing fingers is not where we want to get to. But ultimately, there is an element of accountability. And for, I don't know if there are any medical directors in the room, one of the things that the GMC ELAs, the Employment Liaison Advisors, want to know is they want to know about every never event that occurs and which clinician, was there a doctor involved. And that sends a slightly mixed message to organisations. I certainly believe if things have gone wrong, they should be looked at, but trying to disaggregate the sort of blame narrative is important to take that away. But clinicians, and I make that clear to the consultant body, is that ultimately they have an accountability to what happens to the patients under their care. Going back to a point I made earlier, managing, tackling never events is a continuous process. It's like the fourth bridge. You have to keep working over and over again. A lot of the issues that we do see are factors that are well recognised. Confusion over site, left and right. It becomes a real, when you see an event related to that, it is incredibly frustrating for those looking at it and actually the clinicians involved. The other thing we notice is that some errors, when they occur de novo, are likely to happen again. And that probably highlights that there is a gap in the system. So we had some nerve block issues, and we had a run of 2. And then you think to yourself, well, is there something going on in that department, in that team? And so when I see a never event now, I say, right, where else can this occur? Because I then worry that the actual underlying process for that is actually not right. We do regularly enforce practice, so the so-called ladies from my trust at the front, they spend a lot of time rehearsing and actually getting to reinforce processes. Ultimately, though, and I'll finish with this, it is a collective responsibility, but all clinicians involved in the care of patients, there is a personal, and if not a professional, accountability that underlies it. Thank you very much.
Thank you, Tim, and to all speakers for 3 fantastic presentations. We do have some time for questions via Slido, so if we can switch over to those to see what are the most voted questions. So I'll take the top one first. One of the human factors speakers said earlier that if it's possible for an error to occur, then it will. In this context, should we still be using the term never events? I like this question. Fran, would you like to give your view on that?
I must admit there was one, you would have gathered from my presentation, I think one of the key roles of never events is they act as a window into organisational leadership and safety culture. I would have liked to rename them governance events, because that sense of, instead of asking, who was the clinician involved, maybe that would just shift people towards thinking, what was the part of the system that should have protected patients and clinicians. You wouldn't call them never events if they never occurred. It is this horrible dilemma of they are not the worst events. They are there because, in theory, their occurrence tells us something about what an organisation is doing with safety advice. Very, very open to suggestions for other terms, but I do think every time we've put that out to consultation, the opinions have been so violently different on different sides. It's not been one with a majority vote for any way forward.
Tim, Nigel, would you like to add anything to what Fran said?
Yeah, I mean, the phrase never event is quite interesting because it gives the sense that it's some life-threatening issue. Now, clearly it can be, But some of the never events that we've been involved in, actually the perceived harm or the actual harm is relatively low. But as Fran says, it does reflect probably something around the governance and the culture that's going on. So it's more of a flag to some extent. But never events is a very emotive term, and diffusing it may actually help teams to actually tackle the underlying issues.
So I think, picking up on something that Tim said and I said as well, I think that there is a sense of that collective responsibility, but an individual responsibility too, because, and I, the terminology, I get the question, and I've no kind of fixed view on whether we should call it that or whether there's a better term if we could come up with one. But I think, in general terms, thinking about the patient as the most important part of the team that you're working with, and at the end of the day, many of these things, if we do have all of those bits of our process right from top to bottom, end to end, there are things that we can prevent happening. And, as Tim said, they've got a range of effects upon the patient, but I think they have allowed us collectively at individual level, at trust level, at ALB level, to begin to do some thinking about the sorts of changes that need to be made. And we all reflected upon what some of those are. So, has it been a bad thing to have called this series of things never events or some other thing? I think it's allowed us to put a focus on it. It remains to be seen if we can rename them in the future. I don't feel...
Because I think what we've learned is that language matters, right? Language
does
creates
matter.
the world that we live in and the perceptions of what's acceptable and unacceptable.
I think what you've heard today, and I wonder, would it have been the same a decade ago? I think you've heard us say that what these do is give us an opportunity for learning, for talking to organisations as well as individuals about the culture in which they work, in which the environment can be made safer for the treatment of patients. And I think that slowly but surely, I think that's a really important change.
I'm going to go to the second one, which is what I would call something about always conditions. So, given the evidence linking safe staffing to patient safety outcomes, should staffing fall below agreed levels, and it's just moved, ratios, be classed as a never event? So, reversing the perspective to the conditions of work. Fran, please.
I would just link in, the sense that a never event, as it's defined, is not something we wish wouldn't happen. If there were things we desperately wished would not happen, it would be a very different list. I would have on the list no one ever dying through suicide. I would have no one ever getting a pressure ulcer. I would certainly have no ward having everything other than perfect staffing. These were never intended as the priorities. They were intended as something that if they happened, they were the horse on the motorway, That horse in itself might not do any harm, but it told you there was something else you had to go back and check. So, I would love a world, I think we're all working for a world where we have the best staff we can. But saying something, Stephen will probably have terms for how we do that to ourselves. Putting something on a list because we don't want it to happen is not what these are. These are on a list because they're things we already believe most of the time, with good governance, good leadership and teams, will not happen. And that's why I think it's a bit different to the challenge of the staffing we all want to have.
I think it's important not to conflate two things. I mean, staffing levels, I think most trusts focus on every shift. In our organisation, we're very conscious about staffing. Using the word never, and I understand what it's trying to highlight, the importance, which I think is right. But I think using it in that way, I think just adds to, it makes it more emotive. And I think we should actually just have a different way of expressing that staffing is critical. And I think a lot of work has been done. But the piece about nursing ratios, I think most organisations, most exec teams are actually super sensitive to the numbers of staff, and certainly I think most organisations I've either worked in or been to visit certainly flag that as a very high priority by shift.
So, I mean, in my industry, if not enough air traffic controllers turned up for work, then sectors would be closed down. Or if a co-pilot did not turn up, then the pilot would not fly. Hospitals are different, but how could I, as a patient, find out from my local hospital if it's adequately staffed?
So one of the things that I think that the good and outstanding organisations are doing, and something that we at CQC are interested in, is how trusts respond to the variation that occurs in demand. And so what is the escalation policy? In other words, that peripheral vision to say, actually, do you know what, we're reaching a position where either through not having the ideal staff number to start with, or in a maternity unit, the conditions change in terms of the number of women in labour or the acuity of the patients that are in labour. How do they respond to that? And so being able to see and talk to people about how they're alert to a situation that is deviating from the normal planned staffing and activity level, how do they respond to that? And often it happens in the acute sort of environment, and that's one of the things I think we're all beginning to get interested in. And I think it speaks to me of actually people being much more aware of what the conditions for safety and potential risks to safety are, and if you sense moving from one to the other, what are the immediate steps that you're able to take. And that's true also of multi-professional and team working. Yes. And Tim alluded to that with his teams looking out for each other and being alert to some of those things.
I mean, I guess for me, what the term puts emphasis on is, if you like, failures of workers done, of frontline sharp-end work. But we don't have a similar emphasis on failure of blunt-end work. We don't have a similar emphasis on failure of regulation or failure of management or of resourcing. They don't seem to have parity, those two things.
So, Stephen, do you think we're still, so that the airflow meters need one leader in an organisation to buy some nebulizers, hand them out, confiscate the nebulizers once? So, perhaps part of the problem is that the focus is too much on the sharp end, because never events were intended to shine a light on the blunt end. What is an organisation doing in terms of introducing WHO surgery checklist, having those right environments. And that's why they're different of themselves. I think there's some wider questions, we're not all the right ones to answer. But I had an analogy I'm reluctant of making, because Stephen used an analogy about people who haven't been in the front line for quite a while, imagining what it's like. But I think the dilemma was the same. I can remember as a young directorate manager, deputy director, having my infection control nurse in one ear saying, if you open that unit before 48 hours and someone dies, that's on your conscience. And I had A&E saying, if you don't open it, we'll have to close. The patients will have to travel 30 miles to the next ED. Someone will die, it'll be on your conscience. We need to support our leaders to make brave decisions for difficult things, but we need them to hold an account when there's a simple thing an organisation can do to save 2,000 staff and 100,000 patients' grief. It's getting them in the right boxes is the challenge, isn't it?
Well, that takes us up to break, and please join me thanking Fran, Tim and Nigel for their presentations and contributions.